if they are alcoholic, they are at higher risk of that as well. Idiosyncratic Delhi, it's difficult to be sure about its incidence, but we all think that the incidence is rising, and that's probably because we are prescribing more and more medications. And not only that, more and more medications are coming to the horizon and we are using them. But also that the data is, or the majority of the data comes from the retrospective studies and can be potentially biased because it's mostly provided by the pharmaceutical companies who create those drugs. Another difficult thing is that the traditional complementary and dietary supplements, especially in this part of the world, can cause delay and can be difficult to diagnose because people don't often offer them as the medications that they have been taking. And therefore, the careful history becomes very important. However, there are some prospective studies available on Delhi. For example, the GP's research database in the United Kingdom. There are some European studies who have been on Delhi. United States created the Delhi network in 2004, and Latin American network is also there. And the incidence reported by all of them seem to be ranging between 14% and 20%. Sorry, 14 to 20 per 100,000 per year. And there are some other single center cohort studies available. I could only find one center who has published their study on Delhi from Pakistan. There may be others, but I could not find them. And in this one, there are some interesting figures. For example, more than half of them are men as opposed to the Western world, where there tend to be more women. Cholestasis seems to be the commonest pattern in Pakistan. And not surprisingly, antituberculous treatment seems to be implicated in quite a lot of people, in about 2/3 of the daily cases. Wide variety of the presentations and quite high mortality, unfortunately. Diagnosis, you need to, because of the wide variation of the presentation, you need to have a low index of suspicion. You will find raised liver enzymes, of course. They may or may not have symptoms. There's this particularly notorious DRESS syndrome, which has significant mortality as well. And unfortunately, many of them don't have distinct features. Again, this is not something that I want you to read in detail, but just to point out that there are many phenotypes of DILI, and our focus of talk today is, of course, drug-induced autoimmune hepatitis. And there are lots of medications which can be implicated by each of these phenotypes. Again, antibiotics and others feature there. There are three main patterns: hepatocellular, cholestatic, or mixed. And like I said, the diagnosis is an uncertain process. You need to have low index of suspicion. You need to be aware of the various medications and other stuff which can cause this. Imaging is important, so rule out the other causes. And there are other diagnostic helpful things there. Prognosis and natural history, again, is variable. The grading severity can be very variable, from being very self-limiting to being quite severe. Blood test monitoring is the main thing that you need to do. Vast majority, of course, recover spontaneously. However, there are reports that a significant number of people can have chronic liver disease caused by DILI. Coming to the autoimmune hepatitis, however, prevalence seems to be similar. And again, we think that the incidence is rising. For example, in some European countries, we feel that the incidence has doubled in the last few years. It can affect all populations. 1/3 of the patients would present with cirrhosis right at the start, and clinical diagnosis, we'll talk about that a bit later. And again, I could find one center in Pakistan, Abbas group, who has produced, this one is the SIUT group, Dr. Zafar Abbas group and Nasir Lux group, who has produced papers on this. Interestingly, it seems to be like everywhere else, it seems to be female predominance, but vast majority of the people seem to be cirrhotic right from the start. And a very significant number of them have decompensation. So that's interesting. So how do you diagnose autoimmune hepatitis? Well, a variety of things. Firstly, you need to be sure that there isn't anything else going on, so rule out other causes. There are a number of funny tests that you can do, all those autoimmune profiles, and of course, liver biopsy at the end. And once you've done them, you put them on the scoring system. And once you have done those scoring systems, you come down and find out whether this scoring system tells you that's definite or probable or possible autoimmune hepatitis. So once you have diagnosed autoimmune hepatitis, almost everybody would require treatment. And however, the problem is, or particular problem is this drug-induced autoimmune hepatitis and DILI. How do you differentiate between the two? Because they share lots of features. So just under 10% of all autoimmune hepatitis are caused by drugs, and just under 10% of all DILI have DILI-induced autoimmune hepatitis. And then again, just under 10% of the people, you cannot be sure. Whatever you do, you cannot be sure what you're dealing with. So again, there's no single diagnostic test that you can do. Clinical features help, laboratory tests help, liver biopsy also helps. But like I said, even with the liver biopsy, you are not sure what you're dealing with in about 10% of the cases. Genetic testing has a limited role and does not always help, and is not readily available. Treatment for DILI is mainly withdraw the drug and see what happens. Vast majority of the people will recover spontaneously. In autoimmune hepatitis, you aim to have a complete resolution of the biochemical and histological problems to prevent the progression, and therefore you end up treating almost everybody. Now, this is probably my last slide, just to say that when you are not sure what you're dealing with, the EASL guidelines in 2015 came up with a simplistic view of what you can do, and does not apply to everyone, but is helpful in some cases. And when you're not too sure what's going on, you can put them on steroids and see what happens. If you don't get any response, then obviously you need to consider the other possibilities. If you do get response, you withdraw the steroids gradually. And if people relapse, that confirms the diagnosis of autoimmune hepatitis. When there's no relapse, it's very likely that you have dealt with DILI, and you then avoid the medication that you have been using or the patient has been using. So, ladies and gentlemen, Mr. Chairman, in the last 15 minutes, we have talked about various aspects of DILI, drug-induced hepatitis versus autoimmune hepatitis, and difficulties, and how we can come up with the best solution for the diagnosis and initial management. Thank you very much for your attention. Don't know if it is question answer now or at the end.
Any question? Okay, we should then move on. Let's.
There's one question.
Okay, please.
Yeah, I deliberately kept it low key, because although it's in the guidelines, but that only applies to a small number of people. And very good point that you have made. Unfortunately, not everybody will respond, and unfortunately it can harm, it can cause problem, it can actually kill people. So you need to be very careful. The most important thing is to make sure that they haven't got sepsis of any kind. If you got sepsis, which mimics DILI, or they have DILI, but also they're septic, then steroids are probably going to cause more harm than good. Thank you very much.
Thank you.
Thank you, Dr. Zafar Abbas, for a wonderful talk. Next talk is by Dr. Sadiq Memon, Professor Gastroenterology at AIIMS, Hyderabad. and he's going to talk about understanding exocrine pancreatic insufficiency. Dr. Sadiq Payman, please.
End of session. Okay.